Doesn't seem locked in.
Glad we were able to. So what you got a whole bunch of talks today following
Yeah, here and they're going over to get. I think they want the same presentation. I don't know whether they're getting money or not.
St. Joe's. St. Joe's. More of a community type
Yeah.
of hospital. But my wife's an actor, and she used to work at it. She used to work at it. And got to just
Still doing their rounds.
issues from down there.
I don't think. I think it's this week.
Because they are a community.
I don't think
Best as I
they'll
can
allow
tell,
me.
they're
It's not
very.
going to allow me.
Okay.
So I'm just going to try one more thing.
A lot of long-term care stuff happens there, so
Whole sections.
completely difficult. Yeah. Let me just see if VGH colleagues, can you hear me? Yep, thank you. Thanks, Naomi. So I'd like to get started this morning. It is my privilege and honor to introduce Dr. Paul Boucher. And Dr. Boucher comes to us from the University of Calgary and Foothills Hospital, where he is the medical director of their ICU and is leading the charge related to patient and family-centered care in the critical care environment. He, as best as I can tell, is the one who spearheaded this and has now taken on a role through the Institute of Patient and Family-Centered Care as faculty, educational faculty, and has spoken around the world on this topic. And it's our real pleasure to have him here today. As part of his visit to Vancouver, he'll be giving rounds, of course, and also meeting with members of the organization here at Providence Healthcare and helping to spread the word regarding this type of patient and family-centered care. So it's my pleasure, Dr. Boucher, to have you in Vancouver, and thank you for accepting our invitation.
So good morning, everybody. It's always interesting to throw a critical care doc in the middle of a bunch of cardiologists. But anyways, I'm also a CV intensivist, so maybe a little closer to a lot of things that you do. So really what I'm going to talk today is about the concept of patient and family-centered care. And I think, there's a room full of providers. I think a lot of people are maybe very comfortable with what that means at the bedside. But what I wanted to speak to you about today, which is, I think Providence has done a lot of work on this already, is really how can we expand that beyond just the provision of clinical care. So there's the objectives that we're going to discuss. And at the end of the talk, I'll talk to you about what I do, which is really, not really a broad institutional effort. It's really more of a grassroots approach that may be very applicable to a lot of you. But I'll just explain what it is exactly that I do in Calgary with my group there. The only disclosure that I have, as already mentioned, is I'm on speaking faculty for the Institute of Patient Family-Centered Care. And a couple times a year, I go and help them give seminars. So this is the Foothills Hospital, and this is where I work. It's a large footprint. Our solution to space is just to build more buildings. We have the luxury of some availability to be able to do that. The problem is the place has grown to over 1,000 beds with one infrastructure supporting it. So it's a huge place. A new cancer center is probably going to go in the next couple of years. And the intensive care unit's got 28 beds, and our CVICU's got 14 beds. And our surgical program runs just over 1,000 cases a year, and we don't do transplant, but we do have a VAD program. So that's me, intensivist by training, and I guess maybe I want to be cardiologist for having spent a year learning to do echocardiography and working in the CVICU. So what is patient and family-centered care? I think it means different things to different people, and I think a lot of lip service gets paid to it without really understanding what it means. And so, people have defined this in different ways. I think the principles are there. It's really just about dignity and respect, information sharing, participation, and collaboration. But what does that mean exactly? And I think if there's one thing you take away from this talk, I do a lot of work with our medical association because they've been trying to get into this as well as an association for physicians across the province. But it's really about doing things with your patients rather than doing for. And if you can remember one thing from this talk, that's how I ground people every time they come to me with a concept. Is it really doing for patients, or is it doing with them? So this isn't new. At BMJ, this is the cover from the BMJ from about 1989. So this whole concept of patient partnership isn't new. And I'm not suggesting that you do this with your patients because that gets you into trouble with the college. But really when we do with rather than for, part of it's the provision of clinical care, which we'll spend a little bit of time talking about. But what about beyond that? What about the way we organize healthcare, the way we organize our critical care units, the way we develop policy? What about quality improvement, getting that lens in the work that we do? What about patient safety? And I'll spend some time talking about that. Our patients and families have been our partners in safety ever since the beginning of patient safety. And you may not realize that, but that's really how the whole movement started. And even in unit design. So there's a lot of literature around designing units, using patients and families to help in the design of hospitals, clinics, and intensive care units. So part of understanding this is really trying to understand what it is that drives us in healthcare. You guys are going to leave this room today, and everything that you're going to do today is going to be focused on care delivery. It's going to be focused on patient care. We focus on the patient, to improve outcomes, to give them the best care possible, to improve access. So a lot of what we do is focused on doing things for our patients, not necessarily doing with. But sometimes we do things that are very system-focused. We make decisions as administrators all the time, funding one program versus another, shutting down ORs over the summer for cost savings. Some of that may not necessarily be focused on the patient. that's waiting, on the list for bypass surgery. But as a program, you've got other priorities that in the end are patient focused, but we do some things for the sake of the system. And then occasionally we do some things for the sake of providers. And, that is maybe less common, but when we exclude families from rounds, we exclude them from visiting patients in the intensive care units, we put visiting hours up in the hospital. A lot of times that's really for our convenience. It may not always look that way, but certainly that does motivate some of what we do. But when you turn this on its head and say, well, what if we approach each one of these problems or the things that we do in our everyday work, really putting the patient at the center of it, and rather than doing things for them, we do it with them. And so, I put up these statements and you can look at them and, each one has a driving force behind it. So if you're redesigning, a waiting space or a family space in one of your units, if an architect does that with really a notion that they want to win a prize, and we've won prizes in Calgary for our intensive care unit, it's a very prestigious thing. Sometimes people design things in a very architect or provider-centric way. If you design a waiting room to really match the theme of a hospital because the color's got to be right and it was set up this way down the hall, that's really a system-focused endeavor. You put a committee together to try and say what's best for families. It's a patient-focused but not really patient-centered. You can review your family satisfaction surveys. We do this in Calgary. There's some questions on there related to the environment and a lot of questions around the waiting room. So if you use that feedback to change the design of your intensive care unit, you can argue you're a step closer. But the moment that you involve your patients and families in the design of that unit, then you're really doing stuff with them. Okay? And why is that important? Well, it's important because we don't always get it right. And you may think, we may think we get it right because we're the professionals, we've got the content expertise, and for sure we do. And but when you talk about a true partnership, part of it is having that content expertise, but part of it is looking through that lens. And I can tell you time and time again, no matter what it is I do when I involve patients and families, we don't get it right. There's little things that we miss that when you take a step back, you say, wow, that makes sense. But without that wisdom of patients and families at the table with you making decisions, you miss it. And it's really hard to redesign things, if you're talking, or hard to rewrite protocols. So what does it mean? I mean, at the center of your work, patient-family-centered care is simple. It's about partnering with them. And you guys do this already. If you're a surgeon, you're thinking, patient needs a valve replacement. You have a discussion about whether that's going to be a mechanical valve or a biological valve. You're going to give your expert opinion as to what you think is, maybe the best choice given the patient's age, whether they'll need to be anticoagulated for the atrial fibrillation. You'll have that discussion with them. We do this a lot, and we've done this more over the last 20 or 30 years. Our population base, our patients and families have become much more educated and much more involved in the decision-making. Many years ago, we used to do things in a very paternalistic way. And in acute care, we still do that often because we need to. But what about taking that a step further? Finding advisors that have been through, your units, have been through your clinics, have been through, and using them to sort of develop the protocols and the policies that you write. Creating a family panel to be able to do that, or going one step further and actually including them on committees and your policy development. Focus groups are great, and Dana-Farber, I'll speak about them in a couple of slides coming, but Dana-Farber is a cancer hospital, cancer service line provider out of Boston, and they've done a ton of work with patients and families. And focus groups give you something, and sometimes you need that, because having one or two representatives on a committee doesn't give you the lens of a broad population. And so focus groups are important, but they don't give you everything that you need. So does this actually make a difference? I mean, I'm an academic in an academic institution. It's hard to come here and not present some literature, especially to a group of cardiologists cardiac service providers where you guys live and breathe evidence-based medicine every day. Well, there's not a lot. And so, this is a VA study, and you can argue that VA patients are different than the population in general. 98% of them are male, at least from this study, that really looked at indicators of quality and acute MI care and people's outcomes. And they got about almost 2,000 patients across the states that actually they managed to receive surveys on that are based on a Picker Institute survey looking at patient-centeredness. Now, those that scored high on that scored their institution high on patient-centeredness had a better outcome. Now, the numbers there aren't great, right? But this is the kind of literature that's around there. It's not fantastic. It's not going to move things in a major way, but there is a signal there, I think, that the more we involve patients in decision-making, the better they'll do. There was a psychiatrist when I was a medical student who said something that took me probably 20 years to understand. What he said to me, Paul, he said, when a patient's having a side effect to the medication, they're having a side effect to you, which I really didn't understand. It took me 20 years to sort of really understand what that meant. But, if you don't partner with your patients to say this is important for you to take, any little thing that happens to them with their medication, they're going to say, I'm having a side effect and I don't really see the importance of taking this medication. And so, I think maybe that's what he was trying to say. The survey from the Picker Institute really looks at a bunch of different things, but really what people scored high, those that did better, that scored higher on things like access to providers, the coordination of care, and really attention to patient preferences, which I think is really important. Now, I don't know if you guys saw this study, or this paper really, because it's not a study, out of Jack last year, that really sort of built on this whole concept of the heart team. And I think part of what I witnessed this morning in Rounds is really about that. Really, it's about getting multidisciplinary providers together in terms of when you have to make difficult decisions, whether it's around valve replacement in a TAVI program, or whether it's around complex revascularization. Really, what they called for in this paper was really including your patients and families in that team. And I don't think this concept is new, but really what they're calling for in this paper is to really take that a step further. Now, if we take a step away from the bedside and we move towards more what people can do from an organizational standpoint, Dana-Farber comes up again, and this paper really just highlighted a prize that they won in the States about embedding patients and families on their safety committees, their medication reconciliation committees, and reducing errors. And there was a lot of people reduced errors across the States, but they touted in Dana-Farber, they sort of had the greatest reduction, and they touted the success for that really being the involvement of patient and families on that. Now, using families in committees that look at critical incidents and look at errors is a stretch, from I think for a lot of people, because it's a complicated environment. And this study really just surveyed patients, families, and providers about not just involving, a professional advisor on a review committee, but actually involving the patients and families that were involved in the incident on the review committee. And so, not a lot of people have done that. I think you'll see this group probably take that a step further. But really, the overarching theme from this paper was that they thought that would be beneficial. And so, it's a leap, a light year ahead from where most people are in terms of involving patients and families in different things. But I thought that was really interesting. So, on this theme of patient safety, if you think about it in broad strokes, our patients and families really have been the champions of patient safety ever since the beginning. And I think as providers and administrators, we've used that voice to leverage things. When I moved to Calgary as a medical student, I thought it was crazy that there was vials of potassium chloride on the units right next to, the saline that the nurses used to mix medications, to the sterile water that was used to mix medication. They looked the same. And I got there and I said, this is crazy. Why do you do that? Someone's going to make a mistake. Well, this was me as an R1, in a new place, and everyone thought I was crazy. And so about 2 years later, someone died, but, the family didn't really say a whole lot. I'm not sure what was explained to them. It wasn't until the second incident that really the whole Calgary Health Region said, we've got a problem. And they used that patient and family. They used that patient and family to really drive that message home.
Your
and then,
attention, please. There will be a staff immunization clinic from 8:15 till 11:45 and 13:30.
You guys get your flu season later here than we do. Or is that immunization for something else? So, because I think we're out of vaccine in Calgary. Everyone was very mad.
Being done today.
Anyway, sorry. So.
Your attention, please. There will be a staff immunization clinic today from 8:15 to 11:45 and 13:30 to 15:30 in the Comox Building, 4th floor, room 422. Please note there will be no TB skin tests being done today. Thank you.
All right, sorry. So, and there's a lot, if you look at the cases, of Louis Blackman and Josie King, those are both children that suffered critical incidents in American institutions that really brought forward the whole concept of an emergency medical response team or a MET team. And that really drove, that safety piece home. And so we've used this as healthcare providers. We've used our patients and families that have suffered ill events to really, help us with that agenda. And they've helped, they've been our partners in this in a long time. So, to involve a patient or family in a critical incident review or put them on a safety committee, they've been doing this with us for a long time. So if you just think outside the box for a second, it's really not that much of a stretch. So what about critical care? So this is the environment that I work in. I work in a cardiovascular ICU. I work in a multi-system med-surg trauma unit. What about critical care? And critical care is different. It is different, isn't it? Our patients are sick. A lot of them lack capacity. A lot of them get lost in the sea of machinery. Speaking of immunization, this is our ECMO room from 2009. So we had 7 patients run over the course of about 3 to 5 weeks. We had 4 cohorted there in the room. And I like to show this picture because can you count how many people are in the room? How many staff? I can tell you none of them are families. But there's a lot of them, right? We got nurses, we got perfusionists there, we got another perfusionist hiding there, we got an x-ray tech behind there, And then we've got our patients, 4 patients, and then there's me balancing on the windowsill taking the picture. So, we lose a lot of times our patients within the things that we do. They get dehumanized, hooked up to machines, swollen. It's hard for us to really recognize who they might have been. Our environment's technology rich. Most of our patients lack capacity. Even when we think they're okay, they're actually not okay. If you do delirium scores on them, their attention, the amount of encephalopathy that we see in acute care medicine, not just in the ICU, is very high. We lose lots of patients, right? Maybe less so in a cardiovascular intensive care unit, but the mortality in a general systems ICU is 16 to 20%, right? Depending on your acuity and I guess how good of a job you're doing. We do procedures at the bedside, and we have problems sometimes with confidentiality. We've got patients that are all cohorted together, just like that picture that I showed you. And it's a tough time for families, isn't it? Right? We've got complex situations. We've got families that are in crisis. We've got difficult decision-making at times. And we have a model that traditionally isolates patients from their families, right? And isolates families from us, whether it's during rounds, whether it's during procedures, handover report. We tend to exclude them, right? We're a barrier to them being involved. And we have challenges with our communication. When we look at our family satisfaction surveys, and when you look at the literature around family satisfaction surveys in ICU, we score poorly on communication, access to physicians, information, that kind of thing. We have a strong clinical culture. We know how to do it best, right? Both from a physician standpoint and from a nursing standpoint. And there's times where that's important, right? There's times where there's no room for negotiation. Things need to happen, right? And that's the culture that we live with. It's probably the last place in the hospital where we still provide lots of paternalistic or maternalistic care. So what about the family? So really our focus a lot of times at the bedside is of the family because the patients lack capacity. So who are the family? And people have tried to define this in many different ways. Here's a crack at it from different places. But really, I think a lot of times, we have to look outside the box when we define a family. And really, a lot of times what we're doing is welcoming whoever has arrived with the patient, right? When that patient decides to bring their neighbor to the hospital with them when they're sick because they're estranged from the rest of their family, that's an important person in that person's life. My wife sent me this. I think she's one of those Instagram addicts, and my daughter is too. But I think, the whole concept is, what a traditional family is legally, when it comes to try to inform decision-making at the bedside and sharing information. Sometimes we have to think outside the box. But I think it's important to realize, in acute care medicine, we don't always get it right. We don't always have an accurate list of medications. We don't always have an accurate list of allergies when someone comes into the hospital. We may not actually have an accurate understanding of what the family is when someone comes to us. And you have to be ready to make mistakes. Right? And I don't know about you guys, but the worst patients to get are the truck drivers, right? Because they usually wait with their chest pain for a long time before they come in. They drive a long time to get home, and many of them have more than one family that don't know about each other. So anyways. So, in critical care medicine, the American College got together and said, patient-centeredness, family-centeredness is important. And after a structured literature search, really came up with guidelines based on a whole bunch of things. And I just put this slide up to really show that if you look at these sort of, from 10,000 feet, those principles of patient and family-centered care really dovetail with a lot of what we're talking about. There's a lot of homology there. So in terms of practical examples of how to do things in critical care, a lot of it really is about establishing the presence of the family. And I just wanted to take you through a little bit of literature around both of these things, the family presence on rounds and family presence during resuscitation, just as an example of what can you do in your units to involve families at the bedside, maybe more than you're doing already, or maybe you're doing a great job with this already. So as much as this was enforced or recommended by those task force guidelines from critical care medicine, there's really not a lot of evidence to support this. And so, if you look at a lot of the softer studies that look at just satisfaction of family members, yeah, it goes up. There's when people have looked at the interactions between families and the care providers, there's been provision of information that's helped patient care. And there's always this fear that this is an academic institution. I'm going to pimp the resident about the 14 causes of this, and aren't they going to look stupid? And when they've actually surveyed families about that whole teaching experience, actually their perception of the residents and medical students is higher. Even if they don't always get the answers right. And I would say in my own personal experience, I think that's true. There's something for families to experience the way that you provide care. I think it shows a lot of the dedication that you have at the bedside, and I think it really does improve relationships. This is, again, a lot of this literature comes from the nursing journals, and this is one that comes from there. The FS24, that's the modified Azuli survey. I don't know if you guys are using that here, but it's a pretty widespread survey of family satisfaction and decision-making in critical care. And they administered this by telephone, both survivors and non-survivors. Before and after, they developed a program for having family presence on rounds. And really, when they developed their program, they actually did pretty well. At least 70% of the families had been present on rounds. And really what they found was that they were higher scores in terms of satisfaction for the most part. The one caution is the last bullet on this slide that really, I think it's important when you have families on rounds that we can't lose sight of the fact that sometimes we need to take them away and sit them down and talk to them about things, because they found on their survey was that after they'd implemented family presence on rounds, the amount of families that had scored the highest scores on more than enough time to have their concerns addressed came down. So I think it's a great way to share information. It's a great way to get information from families. But I think we can't forget that there's other ways. Sometimes there's other conversations that need to happen away from the bedside. Now, there is a difference between having families present on rounds and having families participate on rounds. And if your rounds are like you guys do multidisciplinary rounds in your units here? So, if you close that circle and the families are sitting at the doorway, or you crowd around and don't include them, or don't ask them any questions, or don't have them participate, that's different than doing the opposite, right? So including them in the circle of discussion, having them have an equal role, as just like the pharmacist, the nurse, the respiratory therapist, the medical student, the dietitian, the physiotherapist, the family, right? And or the patient, but a lot of times they really can't participate in this. And so people have looked at this, how can families share in the management plan? A lot of times there's things that are not negotiable when people are really sick. You just don't have a lot of room to negotiate things. But there's other times where patients' preferences and families' preferences can impact on care. And when this works well, it works really well. We've got some family members that have been through the intensive care unit, have been there for a long time and understand the history, and I'm there on rounds and saying, well, maybe we should try this painkiller or try this thing to help him sleep. And he's like, Doc, last week we did that and it didn't work out so well, and they actually can help sometimes with the continuity of care. So if you educate your families well, this process can be very beneficial, I think. Now, the problem is we don't really understand how this works. And it's one thing to say we're going to have families present on rounds, but it's another thing to sort of have a method to conduct them. It's another thing to facilitate them, right? I mean, rounds happen between 9 and 11, right? And we're not sure when we're going to get to your loved one. And so is there a way to sort of tell families we're going to be there in 5 minutes and we'd like you present if you'd like to be? How do we measure the outcomes? And what about the time factor? The biggest argument here is that it takes too much time. We're spending 5 minutes at the end of each patient talking to the family. That's making things slower. And I guess my experience with this is that, yes, rounds do take a little bit longer, but probably saves you a lot of things. It saves you in terms of, having families in crisis that haven't been communicated with that can take up hours of time, during a week. And probably saves on the, the sitting down conversations to a degree, because you're sharing information continuously. And what are the rules of this? I've had some family members that don't want to participate. It freaks them out, and that's fine. I've had others that have been very disrespectful in their relationship with us, interrupting other people. I've had to tell them, what are the rules here? Well, the rules here, we're all equal partners, right? So the medical student doesn't interrupt the nurse, right? And the pharmacist doesn't interrupt the respiratory therapist. We don't interrupt you, and you don't interrupt us. And that's really, when you think about it, that's really what a true partnership is, isn't it? If you level that playing field and the power differential is lessened, there's always going to be a power differential, right? We're the ones who hold the knowledge. But if you lessen that power differential, then your problems are easier to solve. I'm not saying they all go away. So what about family presence during resuscitation? This one's always a fun one to talk about because a lot of people are very much against this. Others are very much for it. But if you look at surveys of attitudes, they vary. But for the most part, they're pretty negative amongst healthcare providers. And there's lots of good reasons for this, right? We can't do our job. They get in the way. This is traumatic for them. But people have actually looked at this. And so there's a lot of anecdotal reports from families saying, yes, this was beneficial to me, or provider reports saying that, this wasn't harmful to our provision of care. But these guys actually surveyed folks and tried to ask the question, would you want to be there under these circumstances? And, it's not overwhelmingly for everybody. If you look at the number there, scores around 2.9 out of 4. So it's not a universal undertaking on behalf of families. But a lot of people do find it beneficial. And the scores were higher in patients or families that had actually been through a resuscitation. Now, what about the patients, right? Because a lot of times that comes back to me in my institution. It's like, well, we need to look at this through the lens of the patient. Would they want their families there? The scores are positive, but also a little bit lower. And I think that is an important question when we're talking about confidentiality. You're having a family at the bedside. Who should be there? What do you think the patient would say? It's really hard sometimes to get a straight answer out of families about that because they say, oh, no, they would want me to be there. Is it bad? Well, Probably not in some ways. When you look at this was an interesting study that looked at cardiac arrest, both pediatric and adults in the emergency room, and they surveyed families to death. They administered 7 surveys to them after they were through their event. And there was a lot of crossover because some families didn't want to go and see what was happening and some would not be kept out, which is kind of interesting. And so really, it was an interesting study. There were lower scores in terms of anxiety and stress in the families that had been through the arrest, but with like 20 families, there's no way that was going to reach statistical significance. But at least there was no negative effects that came forward. But I think, there's literature to suggest this is helpful. It's one of the ways that you can in a critical care area, get your families at the bedside. Some people think it may reduce anxiety. Some people think it may be better in the long term. But is there a downside to it? And I think there is a word of caution here. And so this was another emergency study that looked at a simulation center with 30 different teams with senior and junior residents on the team running an ACLS protocol. And they assigned them to 3 different situations. One was with no family. Another one was with a quiet family member sitting at the bedside, and then the other one was with family members that were outwardly grieving but not interfering really in the work that they were doing. And what they found was that with, distracting families, that some of the process measures, were different. And so the time to do things that are important, to defibrillate and to give number of defibrillations during a cardiac arrest were less. So what does that mean is that I think it's not all good, and I think you need to be cautious with this. Do you guys do that here? Has anyone ever done that here? Brought a family to the bedside when someone's been arresting? You have. So, I think you got to be cautious. It's not for everyone. It's not for every family, and it's not for every team. I think when you do it, it's probably best to have somebody with them, and often I've played that role. So if I've got a senior medical resident or a senior surgical resident or an ICU resident running the code, I have no problem sitting with the family and taking myself in and out of that situation when I'm needed to assist with the arrest. But I've been at this a long time, and so, it's not necessarily for everybody. Every time that I have done that, the family has been very grateful for it. And so I think there's something to be said there. We put a lot of barriers up for this. But this, if you can really achieve this, I think really what you're talking about is you're really buying into the concept of partnership with all of your families. It's a lot to say about something that's really very small and doesn't happen very often. So what about patient and family-centered care in terms of your operation of your units and your delivery of health care? Advisors are key to this. And how do you recruit them? People do this in different ways. A lot of times we use family members that have complained. I think it's really important to find the right families and patients to do this, because you have somebody who's stuck on one issue. You really need to have them to be able to step back from that and be able to represent families in general. And some of them will tell you they can't, and some of them will remind you that their experience is very narrow. But I think there still is some value in that, but you just need to be careful. You need to educate them. You need to foster them. Putting them on a safety review committee as their first job in your institution is maybe not the best thing. Some institutions have actually used them to hire people, their docs, their nurses, put them on, say this is, to help with that interview process. I think it's also important to set expectations. Some people even put contracts forward for their patients and families, in terms of what they expect out of them. So in Calgary, really what I've done, I wanted to present you a bunch of different things that people have done, across the world and what folks have published on. But really what I do is fairly grassroots. And, and what I have is a committee with family members on it. We report to our ICU executive. They're not really embedded in other committees. People bring stuff to us. We are responsible for our family satisfaction survey. So we're the ones who get the results. We set the expectations back to the units as to the numbers that we'd like back. We do a lot of things around end-of-life care because that's always been a passion of mine. It's kind of how this started for me, and really around communication. We've written family presence guidelines that have created, a bit of controversy across all our 5 units. But our families wrote that about how, families would like to be engaged and how we should try to have them at the bedside. Operationalizing that's a little bit difficult at times, but this is a process. We don't do DCD in Calgary. We've held out for a bunch of reasons, and so we're starting the process now. And after a lot of work, I've managed to get not only a family member, and again, this guy, it's not his first time being a family member on a committee. He's going to sit there, but we've actually also found a patient, who had a bad neurological injury, who was in status epilepticus for weeks, who survived. And so you may find her on, I think that W5 is putting together something, so you may actually see her on television. And so they're going to sit on that core committee. And I think for me as a provider of critical care services and someone who's going to be doing DCD, I think our protocol, I'll feel much more comfortable with it knowing that they were at the table. We've also got a critical care network that reaches across the province, and they've embedded family members on there as well. So what we've done is we look at our family satisfaction surveys. We've actually themed our negative comments to see where we need to improve. And from that, we've targeted educational programs to our nurses and staff and physicians. We do a lot of work around communication. We give all the old pagers that the residents don't use anymore to our family members to try and communicate with them, because cell coverage is not fantastic in the hospital. We've been working on a project with transitions of care from the intensive care unit to another unit with family members that have been involved in that particular transfer. And what we do is we develop these protocols and these projects within our family committee, and then basically farm them out to our multidisciplinary teams to try and operationalize them on the ward. This is one of the projects. This didn't come from us. I think it came from London, Ontario, but our families helped us modify it. So it's just little things like this around, trying to bring back, who the patient is at the bedside. I mean, these are just little things, but I just wanted to bring forward what we've been doing. A lot of what we do is around end-of-life care, and I'm just fortunate that all the family members on my team are fortunate. I mean, have had end-of-life care experiences, so they bring that lens to the bedside, and part of it is that's a lot of what my passion was getting into this. Using bereaved families in this capacity is a challenge, and because there's a lot of emotion that comes with talking about their dying experience, talking about how we can make that better. But it's important to give sufficient time. It's important to have that personal connection, and you got to be ready to deal with grief. Sometimes patients or families aren't ready for that to come and share their stories and to come and be productive in a meeting environment. But the wisdom that people give you is immense. And probably the most important comment that I think I ever heard from one of our family members was, she said to me, her dad died in one of our intensive care units. She said, what, you guys are experts. When you were running that dialysis machine and you guys were, looking after him, it was clear that you guys were on your game. You were the experts at this. But the moment that we decided it was time to let him go, it's like no one knew what they were doing anymore. And so I think, that kind of comment is really, it's important for us to say, what, we have some standardization here that we need to make better, and our families help us do that. The other thing that we do is that some families don't want to go back to the hospital. So I hold my meetings in the evening. I do about 1 in 3 call. So another evening away from home once a month is not a small commitment, but it's really important because a lot of families can't get there. They've got jobs during the day, and we hold them outside the hospital because some families don't want to come back there, for a variety of reasons. And you got to be ready to share stories when you do this. So, and we'll talk a little bit about that at the end. So, we've learned a lot of things about consistency, managing expectations, and diversity. And really, this is kind of what's come out of there. So we've got a bunch of different programs that we've put forward with the help of our families. One is a champion program. It's basically a mentorship program of staff junior staff are helped by staff that are, more experienced in end-of-life care, and they also help bring forward our protocols. We've worked on bereavement package that we give to families when they leave, so they've got some information about grief counseling and, things like funeral homes, like little things that you don't think of at the time. The staff developed this thing called a compassion card, and I've seen this across, different organizations, and, ours has got food on it. Other people have developed compassion cards with music, quilts. A lot of children's hospital have that plaster so you can cast the hand or the foot. There's a lot of things people have done. We've worked on checklists and a terminal weaning pathway, which is kind of interesting. So, this is our champion program. We identify people through lanyards. We've got more people on it now, and we do survey through our checklists, our staff members, and they're actually making use of these mentors not infrequently. We target these champions for education, and some of this is still moving forward, but movement with the palliative care department and actually trying to get them into the sim lab at the university to help them frame some of those discussions with families at the bedside. The bereavement packages are pretty simple, and the other thing is that we've worked hard to try and get our family satisfaction surveys out to bereaved families. And I'll talk about that in a second. The compassion carts, I think I mentioned. Now, the checklist, I just wanted to bring that forward. So, our families helped us develop this, the staff helped us develop this, and I think what was really interesting from the family's perspective, is that they really, they're the ones that put forward, I'll just put it on the second line, this whole thing about, looking after the staff, right? Have you taken a break after your patient died? We don't think about this, right? This came from our families. So it's little things that they help with, but it's just that lens that they come with is just different from, I think, what the way a lot of us think. At the end of each one of the lists is a list of the champions for that unit, so that if there's someone on shift, that they can lean on them to help out. And then the other thing that, again, taking someone off a ventilator at the end of life, you may think that maybe a family member doesn't have a lot to say about that, right? It's a very technical event, right? How do we wean them to make sure they're comfortable? What do we do with the medication? But they actually had a lot of input into this, and so, what I'm going to show you is a pretty technical slide. I can show you more detail of this if you're at all interested. But it's just to try and highlight that the wisdom sometimes that family members bring to a very medical event is very enriching. So the other thing that we used our families for was to how do we survey bereaved families? So the Family Satisfaction Survey has a couple of questions for bereaved families, for non-survivors, they call it. And so, we had never administered these. We had never sent them out in Calgary. And so what we did was we used our families to help us with that. When should we send it? How should we send it? And so, what we came up with was, sending it to the family of rather than to an individual, because you never know, who's going to do that. There's also unit-specific contact information on this card that we send. So the medical director, the patient care manager contact is on there. So when they get that card and they get, after a couple of weeks saying the survey will be coming in 6 weeks, a lot of times families that are really upset with their end-of-life care experience actually contact us and say, I need to talk about this. And so it provides that sort of mechanism for communication. And I mean, I can give a whole talk on end-of-life care, but it's amazing how you can provide the best medical care to somebody throughout their whole journey, but screw things up when they die, and you've messed up that whole experience for them no matter how well you've done. And so it's a very difficult time for families, and we really need to make sure we have an opportunity a lot of times, because a lot of patients don't die suddenly. They die when we say they're going to die. And so we have an opportunity to make that experience a lot better. I think I'm getting to the end of this talk, but I think really, I presented to you a lot of places that are doing things on a very grand scale. I think Providence is up to a lot of things on a very grand scale. The work I do is small, and it's very grassroots. But I got to tell you, the risk of using a grassroots undertaking to try and change culture is that you risk beating your head against the wall for a long time without really changing anything. But things do change, and if I look back over 10 years ago, I remember having one of the very first families on rounds, as an ICU fellow. We just didn't do it, and now, 14 years later, it's strange not to have them, and so, and a lot of this is through just continual efforts at a very grassroots level. It hasn't been, a leadership drive, to try and change things, although I think the most successful endeavors probably come from both ends. There are a lot of challenges to doing this, the intensive care unit. Managing change, we manage change all the time. I think there is something to be said for having strong leadership and vision for that. I think you have that here. Educating people is important. Finding champions of change. And how do you find those? I think, probably the best way to do that is to share people's stories, or actually have people come and share their stories. And when I give talks like this, I actually prefer to give them with a family member and have them tell their story to people, and then have me frame it within a bit more of a, quote unquote academic context, because I think it really brings that home for people. And sometimes, every now and then when somebody shares a story, someone will have what's called the aha moment, right? Where they actually sort of get it, where, we don't look at this the right way. We haven't been looking at this the right way. We need to look at this through this lens. And this isn't, patient and family-centered care isn't about giving people everything they want. It's not about putting marble in the entranceway, or, having a fancy coffee shop, or doing everything that patients want. It's not really that, right? If you think about it, what is a true partnership? If you're in a true relationship and a true partnership, it's about more than that, And, a lot of times through sharing those stories, you really get to people, and if you can change people's attitude and get a champion of change, and physicians are the hardest ones, right? I think a lot of times we're busy, but if you can have some physicians that buy into this, they can really, really help drive change within an organization. Trying to get Joe to send me a better picture of this, but this comes from Trillium, and I met this guy who's actually a maintenance worker, and he runs the maintenance department at Trillium, and Joe built this, and if you want to build one, he'll send me the specs and I can forward them to you. But Joe, it's very interesting, right? Like his perspective is that, even though that they are maintenance people, like really they're there helping patients every day. And, even something is changing a light bulb. He always tells the story where you went to change a light bulb and this woman was crying because she had C. diff and she couldn't get to the washroom all night long because it was dark. And so, he basically tells that story to his guy saying, like, this may just be a light bulb for you, right? But for somebody else, that's their ticket to the bathroom, and they've been waiting for it. So he put this together. And I think his quote that I really like is on the left-hand side of that screen is that if you don't look at patient and family care as something separate, I think that's how you're going to be successful. If you look at it as how do we embed this in everything that we do? So rather than being work, it is the work that we do. And I think really that is the, I think that's a key message, right? And it's in the bowels of the in the hospital in Mississauga, that the maintenance guys see, Anyways, that's really all that I wanted to say to y'all. I think, I'm happy to open it to questions. I think, really moving forward, it's about involving your patients and families in the work that you do, not just the provision of clinical care, but in the way you organize everything that you do. I think that's all I have to say. Thank you very
much. Thank you very much, Dr. Boucher. I'm sure there's a number of questions. I am going to flip it over to VGH if they want to ask the first.
Hello? Can you hear me?
Hi. Yes.
Hi, Paul. It's Graham.
Hi, Graham.
Great talk. Thank you very much. A very, very provocative model that you're putting forward. I was wondering when you first started implementing this, did you get a sense or is there any literature to suggest that the delivery of care differed if you involve patients? Did the strategy, did the thinking, did the biases of the treating team change at all? Were you more aggressive, less aggressive? Did you tend to do things that you may not have ordinarily done? And if so, did that evolve over time?
So I think, I guess I'll answer that question two ways. I think, if we just talk about partnering with patients and families for care delivery, I think we've seen a lot of that over the years. There is some evidence to suggest that when you actually work with patients about, and I think the whole Choosing Wisely campaign, that's started in the States and is coming to Canada through, efforts at the CMA level and others, is really about that, right? It's about partnering with families to try and help them understand what's of value, in terms of the investigations and testing and care that we provide, and also helping us understand what's value to them. So there is literature around, reduced costs, reduced specialty visits, that kind of thing. That stuff is out there. I think, I think we've all experienced this, right? Where we're heading down one pathway to say, we got to do this, that, and the other thing. And then when you finally sit down with the patient or the family, they say, gosh, doc, this is typical of Alberta, right? Are they going to get back to the farm, And so, and then, well, I don't think so. And it's like, well, we got to stop now, So I think there's a lot of that in terms of limits of care. And there's a lot of evidence around end-of-life care planning that really is sort of a patient-centered event. The concept of involving patients and families on committees is not an easy one, and it's not necessarily in everybody's comfort zone. It was very difficult. It was a lot of conversations for me to get a family member on our DCD committee, right? It's like, well, can't we involve them at some point and just run it by them? And it's like, well, no, put them on the committee, right? And I offer for people to come sit on my committee because I was nervous the first time I started working with them too, because I actually inherited them. I didn't go and find them. So it was, it's a different experience, but I'll tell you, there is some literature around it, but anecdotally, the lens that they give you is just, it's so sobering, in many ways. And, as much as we all think we're smart, we all think we do great work, and we do, but there's a lens there that we just don't have. And I can tell you it's very rewarding in many ways. From an administrative standpoint, if administration can be rewarding, it can be very rewarding. It's an eye-opener. And it's provided a lot of satisfaction in the work that I do, just because it's a very different way of thinking of things. Does that answer you, Graham?
I think so. Yes. Thanks.
Anne-Marie.
Thank you for that great talk. I work on the heart transplant team, and every week we make very difficult decisions about whether or not to list people based on a whole lot of criteria. And there has been a move towards thinking about involving either a patient or a community member on that committee. And then for me, there comes the clash with privacy, talking about very personal things about other patients. with an ex-patient perhaps being involved and listening. There's that, and also it's such a stressful decision sometimes that we often use black humour that a patient may not understand to relieve the tension and stress of some of those decisions. Would you care to comment on that and perhaps add some perspective?
So two comments, I guess. The first one is, if you're gonna put a patient or a family member in that kind of environment, you need to groom them. Like, I think that's not, you want to be very careful about who you choose, because that's a particularly challenging environment to work in, and you want to make sure that they have a good experience too, right? And so I guess that's the first thing I'll say. The second thing is, if you're going to put them in that kind of environment, they need to go through whatever confidentiality training you put through your employees, right? And you can often do that through volunteer services, but that needs to happen, right? Because the last thing you need is, something hitting the news because they're not necessarily who you thought they would be, or they don't like what's going on. So you just need to be very cautious about who you choose there. And it may be wise to choose someone that is not their first time involved in the healthcare system in some capacity as an advisor. In terms of the black humor, I mean, I think that's a lot of, that family presence during resuscitation. We use a lot of that too, or even during nursing shift report. I guess I'm a humorous guy. I'm all about levity, and but I guess the question is, should we be doing that anyways? Does it just maybe get people back on better, quote unquote, better behavior? Or maybe you'll find somebody that'll partake in the way that you guys deal with stress. I think, but that is always one of the concerns, right? Is that, we talk about things a bit different here. We joke, they're not going to get it. But I mean, I think they're people like everybody else, and I think they'll understand. If you get the right person, they'll understand the whole societal issue and the healthcare lens too. About what it means to deny someone a transplant or put someone else on it. And they'll get that, right? Because they understand those pieces, right? But I think it'd be worth trying. Does that answer you? Yeah.
Ron?
Thanks. Sorry, I'm trying to use a microphone here. Very interesting talk. You spoke kind of about the spectrums. I mean, there's the planning, there's the rounds, and then we come from the other end on the resuscitation. What about the in-between part? And, patients, for example, will frequently ask, can I come and watch the procedure? What are your thoughts on that? Should they, how consistent should their presence or potential presence be?
I know you're an interventional cardiologist, so I've spoken to lots of people across North America. I don't think I've run into anybody that's facilitated family presence within an operating room environment. There's a lot of, this is a particular concern in pediatrics, right? And so, bringing them into the OR to get the patient induced, that's a change. They never used to do that, right? They used to leave them at the doors so they've changed, a lot of pediatric hospitals have changed the way they do that, but I don't think they've had families present during that. I mean, you could argue if you look at the whole obstetrical world, right? There was a time where husbands had to sit in the waiting room, right? We don't do that anymore, right? They're probably even there when they're doing the C-section, right? A lot of times. And so, there is a precedent set for that. My experience is mostly around, having families present during procedures in the intensive care unit. And, we don't mandate that, but I find it very interesting. So I don't kick them out. I don't invite them in. I don't go looking for them. It's like, we're going to put in the central line now. You need to come and watch. I don't do that. But I certainly don't kick them out. And I've had them around for things like difficult airways, where we've, either the charge nurse has sat with them or I've sat with them while the senior resident's been doing something, and what I found over the years is that less and less, even the junior residents are asking them to leave, which I find fascinating, because a lot of times, the junior people are more uncomfortable with their skills, right? They know they might not get it, right? But I walk by and it's like, well, that's interesting. That resident hasn't kicked out the family. They're still there watching. They've got their little mask on and they're sitting in the corner. And, I think you have to do what you're comfortable with. And I think you also have to understand that this is a process, right? To say I'm here today and, having a family present during the cath, in the room, that's different, and again, it might not be for everybody, right? People might not want to be there, or the patient might not want them there. I haven't heard of people doing that. But a lot of what comes up from families around the time of procedures is the angst during the procedure. And so a lot of groups have really worked with their families on how to try to relieve that anxiety and keep sort of updates routinely, particularly in the cardiac OR, right, where sometimes a 3-hour event turns into an 18-hour event, and, or maybe not that bad, but maybe that just happens in Calgary.
I do notice that we have colleagues on from Victoria and Children's and Women's. I know there was some reference to pediatrics there. Any comments from either one of those sites? I don't see any hands waving. If that's not the case, then Shanta.
Yeah, so just a reference, what happens if a family member says, no, I want the most senior person to do it? And sometimes we get patients say, no, I don't want your fellow to do this. Suppose, the central line, as you said, the family will, no, I want the staff to do it and not him. I mean, how would you respond to that?
I think it depends a bit on the situation. I think, again, it's really about partnership and about helping people understand, what an academic institution is. And a lot of times those anxieties are alleviated by the whole supervisory aspect, so that may be the line where I'm actually in the room, even if the person is, if there's a lot of anxiety on behalf of the family, that may be the line where I'm actually present, even if the person, I've seen them do a bunch and they're actually competent and independent, right? That's something pretty simple, like a central line in intensive care unit, a complex CP, where I know you guys are trying. I think it's really just about partnerships, about discussing things with patients and families. I think a lot of it is that anxiety, so I think it's important for them to understand, that they're in a teaching environment. And then I guess you're going to have to make your decision if they really are adamant about, what they don't want to happen. Then, I think that's every case needs to be dealt with differently. But I think the way that I keep explaining this to people is if you look at it as a true partnership, then hopefully, you'll hear them and they'll hear you. And you'll come to some compromise, right? Just like being married. Yeah. Although
VGH.
Hi, thank you. That was an excellent talk. I was wondering, how much do you have to dumb down your rounds when patients are there? We were repeatedly told that patients can't understand at above a grade 7 level. We've had a speaker come in recently who said that people can't understand the instruction, take your medications, 2 pills twice a day. And in Vancouver, we're a multi-ethnic community. A lot of people do not speak English, so you'd have to get translators in. So I'm just wondering, how does this affect the training?
So it's an excellent question, and you may get different answers from different people, but I'll give you my perspective. I'm an intensive care physician. Rounds are really the most important part of the day, right? That is where, if we're going to make an error, we're going to drop the ball, it's there. And so, those rounds are important. And so I don't dumb them down. We carry on business as usual. I do try and involve the families in, if there's parts of the history, medication reconciliation, things, I really try to get them involved so that they hear what we're saying, but they also feel like they've got an active role. And then there's 2 things that are important. I think when it's done, it's important to explain to the family the highlights of what it is that you've discussed. And sometimes they'll ask questions, what is a CVP, or what is, they'll ask a question and we'll answer it, because a lot of them get smart real quick. And then when you teach around things, it's important to frame that, right? Because if you start talking about differential diagnosis that includes, something like hepatitis C or HIV or cancer, right? That's all the family's going to hear, right? They're going to leave and did they have hepatitis? I've had that a lot, right? And so, you really have to explain, like right now we're going to discuss, some things that your family member doesn't have, and so, I think that is a key piece. And so usually what I do is I summarize at the end, answer whatever questions that they have. But, I had one resident one time who was so into it that when she was presenting the plan, she was presenting, the differential, the problem list and the diagnoses in lay terms to the family. And I said to her, I said, that's great, but I need to hear that you know what you're talking about, and we need to come up with a plan that is make sure the patient gets the care that they need. And the families are involved, and if there's lots of things they may not understand, we'll fill them in, right, and answer all their questions. So I don't dumb the rounds down, rightly or wrongly, that I don't do that, because I think that, that part of the medical care is so important, right? And maybe this is just me still as an old school, attitude, but I do try to maintain, the process and what it is that we do, change it somewhat to try and cater to the families. But I've had some that, have been interrupt so much, that I've actually asked them to be quiet, and to wait their turn, because, we don't do that to each other, so they shouldn't really be doing that to us.
I'm going to take prerogative and ask a question or two. What percentage of your families opt out? Say, I like the old paternalistic approach. And the second question is, when you take this type of approach in the critical care environment and the patient ultimately transitions to a ward environment where they may not have a patient family-centered approach, what are those transitions like, and how do you get a family prepared for the idea that they're going to the general surgical ward and you're not going to get this level of, or high-touch care, if you will?
I think the whole issue of, I mean, there's two parts to that question. The very paternalistic approach to care. There's a demographic, I think, and culture sometimes that is very deferent to opinions of the physicians, and I think you have to be ready to take on that role if you're asked to. And sometimes we just have to, anyways, right? Depending on the situation. And so, but I think that happens. There are some families that don't want to be part of rounds for a variety of reasons. Sometimes it's just the complexity of information, the not wanting to leave the bedside. So I offer all the time. Do you want to come, or do you want to stay? Give you an update right after. And it's a small percentage, but it happens, and often it's the same people. It's a personality that just doesn't want to be part of that, and other people thrive and really want to be there. The patients in the intensive care unit. So I do rounds in the room when the patients are awake. But I think the incidence of delirium, even hypoactive delirium, is very high. And I think even with CAM ICU and ICD-9 scores, we under-recognize it. And so a lot of patients just fall asleep. And so I mean, I try and involve patients in sometimes their physiotherapy schedule, their weaning schedule when they're tough coming off the ventilator. We work a lot on that kind of together to make them feel like they're part of it, and to make staff appreciate too that they're part of it. Your other question was around. Transitioning. So we've got a brand new intensive care unit. So when patients leave, it's like going from the Hilton to, I won't even say it's as nice some places as a Super 8. So there's a lot of things in the transition process, not just what you're talking about. So we've actually been working. We've got a project underway, a team working on that about how do we transition patients. We're working with our neuro unit to start with, as a model. And so that is a problem, and it's a problem between intensivists, right? So even as the medical director, it's hard for me to get people to do things sometimes. I don't know if that happens to you guys too, but so I've got some physicians that really just can't do this, right? Like I've spent hours with them, right? And the nurses get empowered for this, right? They bring the families in, right? Rounds are going to be here, and I've got some colleagues that just, in spite of lots of work, right? All I can do is wait for them to retire now. Because I just can't, really, it's been a lot of work. And so what I've come back with is, this is the way the unit runs. If you can't function in that environment, I'm not going to fire you, because a valued member of the department in lots of ways. But it's your job to explain to them why, is what I've put back to them. I'm not going to do that, right? So we work Friday to Friday. So Friday to Thursday, they have present on rounds, and come Friday morning, you're shutting the door on them. That's your job. You got to deal with that, right? You got to talk to them. And it's not that they don't communicate with them. They'll still sit down with them every day, right, and do things the way they've always done them. But just having their presence on rounds they just can't handle it, right, for lack of a better term. And so what I've done is put that back upon them to say, this is the way I run the unit as a medical director. This is the way 80% of your colleagues are running their rounds. If you can't do it, I understand. I've heard you, right? And we've spent a lot of time talking about this, but it's your job. You need to tell them why, and you need to develop another strategy to communicate with
them. I don't see any other questions in our audience, VGH. Any other questions? All right, as we're approaching the top of the hour, I want to thank Dr. Boucher once again for a really informative and enlightening talk, and enjoy the rest of your time here.
5 tomorrow morning. Here, to grab the 7 o'clock ferry.
Your conference is scheduled to end in 2 minutes. Your conference is now over. Goodbye.